Alright, we're going to talk about lung volumes, and a little bit at the end of this is going to be focused on pulmonary function test. What you need to know is there are two terms that you use when talking about lung volumes. The first one specifically is volumes, the other one is capacities. You have lung volumes and you have lung capacities, and these are measured with spirometry. And what I'm going to do is try to explain to you what the difference between a volume and capacity is, and then we're going to talk about what each one specifically means, but we're going to try to do that in sort of an interactive way. So what I want you to do first is to breathe quietly. Just breathe softly, gently. Go ahead, just breathe in, breathe out, soft, gently. Just your normal breath. It's going to sound something like some meditation or yoga type breathing, just normal breathing. So as you're breathing normally, we can analyze this as the volume you've breathed in and out over time. So if we start off right here would be you're resting, you've breathed all the way out. You take your breath in, you breathe out, you breathe in, you breathe out. This is normal breathing. Now take a deep breath. Breathe all the way in. Keep breathing in. Keep sucking in as much air as you possibly can. A little bit more. You don't have as much as you can. Come on. Really breathe in. A little bit more, as much as you can. Okay, hold it. Now push all of that air out of your lungs. Push every single drop of air out of your lungs right now. If you've even got a little bit of air left that you can squeeze out, keep pushing it out. Now let's analyze this all together. We started off at empty. We were breathing normally, just normal breaths. Then we took this deep breath and we breathed all the way out as much as we could. And now we're back to breathing normal again. Now here's some of the key points. Whenever you are breathing normally, whenever you breathing out, you don't use any muscles. You just relax. And so when you come down to this completely breathed out point right here, you get down to here. At that point, the compliance and the elasticity and the forces of your thoracic wall and your lungs are at complete equilibrium with themselves and with the external environment. And absolutely no muscles are being used because you just relax to let air out. So from this point to your normal breath in, this is called the tidal volume. And I drew it in blue for a reason, because I want you to think of the ocean when you think of these words. The tidal volume, you know the ocean on the tide, it moves up just a little bit and it moves down just a little bit. But it's not enough, it's not as tremendous enough that you couldn't ride it on a surfboard. But the big waves you could ride on a surfboard. So if you think of the little movements as being the tide movements or the tidal volume, that'll keep you straight on that. And as you've seen, that's abbreviated as a V for volume and a subscript capital T for tide or tidal volume. Then the next thing is from the highest point that you can breathe in down to what you would normally breathe. So the top of your tidal volume, anything extra that you could have breathed in, that's called the inspiratory reserve volume. And I'm stressing the fact that it's a volume. And then from the bottom of your tidal volume down to everything else that you could have breathed out, which would be lined up with right here, this right here is the expiratory reserve volume. And then after you've breathed everything out, you still have a little bit of air left in your lungs that you can never actually breathe out. And that, from here to getting down to zero volume in the lungs, that's called the residual lung volume, or we'll just say residual volume. So this is the residual amount that will always be there. So you can see the volumes are the smallest basic units that we can break this down into. So from the top of this tidal volume, if you go up until you find the next breaking point, that is your inspiratory reserve volume. So each of these, where the curves change from being peaked to being troughed, I call these breaking points. That's not they don't actually have a name, but I'm just going to call them breaking points. If you go from one breaking point to the next breaking point, that is considered a volume. So from this breaking point to this one, that's a volume. From this breaking point down to this breaking point, that's another volume. So each unit, each segment between a breaking point is considered a volume. Then you have something else called capacities. Capacities are the sum of two or more volumes. So a specific volume 1 plus another specific volume 2 is equal to a specific capacity, some kind of capacity. Now, for example, if I start from this breaking point right here, I want to include both this and this breaking point. I want to go all the way up to here. This is called my inspiratory capacity. So I'm going to put IC, inspiratory capacity. So inspiratory capacity, that's going to be equal to the inspiratory reserve volume plus the tidal volume. And then if I start from that same point, the bottom of this breaking point, and I go all the way down, I include that breaking point, and I go all the way down to the very bottom to include every bit of volume that's left at the end of a normal breath. This is called the residual capacity, sometimes called the functional residual capacity. But the residual capacity is equal to the expiratory reserve volume plus the residual lung volume or residual volume. So this is a capacity, and it is the sum of two specific volumes. Now, of these two, in the physiology textbooks, the functional residual capacity is the more important one to be familiar with, but you'll still want to be familiar with the inspiratory capacity. And then lastly, there's two more capacities that we'll want to know. If we start off from the peak of this trough, we're going to include this breaking point all the way down to past this breaking point, all the way down to everything that we breathe all the way in and all the way out. So in essence, I'm going to drop from here all the way down to here. This is called the forced vital capacity. Now, it's actually called just the vital capacity, but whenever you breathe it in forcefully, then it's called the forced vital capacity. So the difference between vital capacity and forced vital capacity is whether you're working at it really hard. And the reason that's actually important is because the changes in the intrapleural pressure, which we're not going to talk about, it can actually cause airway collapse when you're being forceful, and so that can bring out, using forced vital capacity can bring out some mild obstruction. And then the last capacity to be familiar with, if you haven't already guessed it, is going to be from the top all the way down to the bottom. This is the total lung capacity. So there you have the 4 capacities that you need to be familiar with and the 4 volumes that you need to be familiar with. And I'd like to point out really quickly that the way I remember the forced vital capacity or the vital capacity is that this is all the air I can breathe in and out. If I ever try, this is where life exists. This is vitas, life. This is where life exists. This is as much as I can breathe in and as much as I can breathe out. Whenever I'm dead, I can breathe everything out and I can still have some of that residual volume. So this is where life exists. It's the vital capacity. Now, just as a side note, things that increase the forced vital capacity, things that physiologically increase the forced vital capacity, is increased body size. A large person is going to have a larger vital capacity. Male gender, males have a larger FVC. And then physical training will allow your FVC to increase because you're constantly breathing at a higher volume, or your FVC, you're constantly forcing air in and forcing it back out, and so it's changing your volumes and elasticity. And then the other thing is a young age. Younger adults will have a higher forced vital capacity than older adults. And the last thing that needs to be said really on this is that the residual volume, out of all of these things, the residual volume is the one volume that cannot be measured on spirometry. So I'll just write spirometry and I'll mark it off. And so when you're using spirometry, you can actually determine all of the capacities and all of the volumes except for anything that includes the inspiratory reserve volume. So the functional residual capacity and the total lung capacity, these capacities will not be able to be determined either from spirometry alone. There are ways to do it. Helium dilution and body plethysmography, those are the two ways that you would determine the residual volume. And I'll talk about those in a second. First, lung volumes. We said that we have a tidal volume, that is about 500 milliliters, so up and down 500 milliliters. Then we have this inspiratory reserve volume, so going all the way up and all the way back down. So from here to here is about 3,000 milliliters or 3 liters, which is, as you can see, it's about 6 times more than the tidal volume. Then your expiratory reserve volume, breathing out from here to here, that's going to be about 1,200 milliliters. And then the residual lung volume, what you have left after everything's already out, that is about 1,200 milliliters. So if you're following along, you'll know that the total lung capacity is approximately 5,900 milliliters. Now, it's important to point out that each of these are estimates. These are estimates or averages for various people, and this is going to change whether you're male or female. And so different books are going to report slightly different values, and the TLC reported by different things is going to be slightly different as well. These are just estimates or nice, easy, rounded numbers to make it easier to remember. And then I've listed here what each of these volumes are. So the tidal volume, you've got to know what that is. But then the inspiratory reserve volume, that's anything extra above the tidal volume. The expiratory reserve, that's anything extra below the tidal volume, down to what you can maximally breathe out. And then the residual volume, that's anything that's left that can't be pushed out. It's like a constipated turd. So here we go again. We have our normal breathing tidal volume, our deep breath in, our hard push out, and then back to tidal volume again. And so we're going to talk about capacity real quick. Inspiratory capacity, that's from the bottom of the tidal volume to the top of that heavy breathing in. So I've got that it's the tidal volume plus the inspiratory reserve volume. Then the functional residual capacity from that same place all the way down until zero volume is left. So zero volume, that would be the residual volume plus the expiratory reserve volume. Then we have the vital capacity, also called the forced vital capacity, also called the forced expiratory vital capacity, or FEVC. And that would be from the top of this peak. I'm going to go all the way down. So I'm going to go all the way down. Down to here would be the inspiratory capacity. So down to here I've got inspiratory capacity plus a little bit more. What is that little bit more? That's the expiratory reserve volume from the bottom of here down to the bottom of this peak. Those breaking points are the expiratory reserve volume. So you've got inspiratory capacity plus expiratory reserve volume, or you could replace inspiratory capacity with the tidal volume plus the inspiratory reserve volume plus the expiratory reserve volume. Then, so this would be the functional or the forced vital capacity from the top of the big peak to the bottom of the big peak. And then total lung volume would include all of this forced vital capacity plus the residual volume. Or you could say that it is the inspiratory capacity plus the functional reserve capacity. Or you also could say that the total lung capacity is the tidal volume plus the inspiratory reserve volume plus the expiratory reserve volume plus the residual volume. In other words, it's a sum of all of the lung volumes. So we talked about residual volume and that it can't be measured with spirometry. The two methods, helium dilution. So first, helium dilution is based off of the principle of if you do volume 1 times concentration 1 is equal to volume 2 times concentration 2. Or instead of using the concentration, I think in a lot of chemistry classes you may have remembered that it's the molarity, M1 V1 times M2 V2, the molarity of the first unit times the volume of that first unit equals the molarity of the second unit times the volume of the second unit. So M1 V1 equals M2 V2, or V1 C1 equals V2 C2. The assumption here, the very good assumption, is that helium does not cross into the blood, that the blood has no capacity to hold helium, and so every bit of helium that you breathe in, you will also breathe back out. So here's the idea with spirometry first. So first you do your spirometry. You got this guy blowing into here. As he breathes out, it's going to lift something up, some bell up, and as he breathes in, it's going to pull that back down, and the moving up and down is going to be basically going to be recorded as it goes up and down, and it's going to keep recording that, and that's going to give you all of the volumes except for the inspiratory reserve volume. And then you're going to add a known amount of helium into the breathing area, and you're going to assume that after several breaths, that helium will become equilibrated in the lung and in the spirometer. So if you know the volume of helium that you added, and you know the concentration of helium that you added, when everything is said and done, the concentration of helium will be diluted, and you can use that to discover what the final volume of everything is. And so that will give you the residual volume. Body plethysmography is a little bit more difficult to explain. The math is a little bit more difficult, but I'm going to try to explain it like this. You start off, you're a person inside of a box. And so here you are inside of a box, and you're breathing in through a spirometer, which is moving up and down as you're breathing in and out. And all of the pressure inside of the box is basically just nice and steady and everything. But as you breathe in, the box is enclosed. There's no communication with the outside. So as you breathe in, your lungs expand, and the volume inside the box becomes smaller. Your lungs become bigger, and so the free volume, the volume the air in the box is taking up, becomes smaller, and so the pressure in that box goes up as you breathe in, and it goes down as you breathe out. And so that's being recorded, and then in the middle of all of it, they put a blocker right here. They stop you from breathing, and they tell you to go ahead and try to breathe. So you breathe in, your lungs actually expand, but the nothing goes into the lungs, and so you can use Boyle's law. Pressure times volume equals some constant. So as the volume of your lungs go up, the pressure will go down, and they can measure the pressure of your lungs. They can put a pressure reader right here, a manometer right here, and measure the pressure in your lungs, the changes in pressure, and they can also at the same time measure the changes of pressure in the box, and they can use that to figure out what the residual or the functional reserve volume is, and figure out what they'll figure out what the functional residual capacity is, and then from that do some subtracting and figure out what the reserve volume is. Now, another thought whenever you're talking about the volume in the lungs is there's a certain amount of volume in your lungs that is used to exchange air, and there's a certain amount of volume in your lungs that doesn't exchange any gases. So part of the volume, specifically the alveoli, so if we have, this is your bronchioles, and then you have an alveoli right here, the gas that goes into the alveoli can exchange with gas in your blood. So CO2 from the blood will go into the alveoli, O2 from the alveoli will go into the blood. But there is no gas exchange in the conducting airway. So if there's no gas exchange in the conducting airway, that's dead space. That's space that's being we'll just say wasted. It's not wasted per se, but we'll say that it's wasted as far as gas exchange goes. Now, an important concept to understand is, before we move on, is that so we have our alveoli right here, and we have our blood supply coming through, wrapping all the way around it, curling around, and then so you have the pulmonary artery. It comes out into these pulmonary capillaries, and then it leaves as the pulmonary vein. It goes into the left heart, and the left heart pushes it out into the systemic arteries. So systemic arteries. And in all of that time, up to the systemic arteries, the only time that the concentration of gas changes is whenever it's in the lungs. Whenever it gets down to the systemic capillaries in the tissue, it'll start exchanging CO2 and O2 again with the tissues, and that'll change again as it goes to the venous side. So the venous side, it's not going to change anymore until it gets back to the lungs. So the two times that the concentration of a gas changes, the two times that they change are at the lungs and in the tissues. And so the gas comes, the CO2 from the tissues comes into the lungs, and then it exchanges with the air. So some of the CO2, there's a whole bunch out here, some of it moves into the alveoli. And I want to know how much moved into the alveoli. And the answer to that is that the pressure here became equal to the pressure here. So the pressure of CO2 in both areas became equal because the blood is near the alveoli for long enough. It just keeps wrapping and wrapping and wrapping around it. It's near it long enough for the gas to become equilibrated between the two spaces. So if I want to know how much CO2 is in the alveoli, I can actually measure the pressure of CO2 in the systemic arteries doing an arterial blood gas. I can measure the PCO2, and I can determine what it is here, and I'll know what it is over here. Okay, with that background, that's going to be important when we go to calculating what the dead space is. So with that background, let's go back and talk about dead space. You have two types of dead space. You have anatomic dead space and physiologic dead space. The anatomic dead space is your conducting airway. Then your physiologic dead space, it's going to include all of the conducting airway plus something called functional dead space. Functional dead space is any alveoli that is getting air into it, but it's not getting blood. So the blood is trying to come in and it's being stopped. So it's essentially an alveoli that's not able to exchange gases even though the gas is moving into it. In other words, it's ventilated, but it's not perfused. It's ventilated with air, but it's not perfused with blood. So then I say, how much dead space do I have? I want to know how much physiologic dead space do I have. And so under normal conditions, physiologic dead space is approximately equal to anatomic dead space, and the functional dead space is very, very small, approximately 0. And then lastly, we can come up with this concept of what percent of my space is wasted. So what percent of my volume is wasted, and that would be the volume of dead space divided by the tidal volume. Now we can have a thought process, a thought game. If we imagine that there is no dead space, neither atomical nor functional, then there would be, so the dead space equals 0, VD equals 0, then VD over VT would equal 0, right? And then so I would say that my functional volume, the volume that's not dead, is equal to VT, the tidal volume, minus the dead space. So that would equal the tidal volume. So the functional space would equal the tidal volume. And so if I did the functional volume divided by the tidal volume, it would equal 1. In other words, 100% of my tidal volume is functional, and 0% is wasted. Okay, so we're going to make some quick assumptions so that we can actually go on and further and calculate what this is. So the first assumption is that there is no CO2 in atmospheric air. We don't breathe in any CO2. Now, of course, this assumption is going to change modestly depending on like what room you're in and stuff like that. But in the normal atmosphere, the CO2 is 0.004%. I think it is something like 4 parts per 10,000 is CO2. So although this isn't a completely correct assumption, for calculation purposes, it's a safe assumption. The second assumption we make is that all of the CO2 that comes out of the lungs come from functional alveoli. In other words, it comes from this stuff, VF. And lastly, that physiological dead space does not contribute to CO2 exchange. So this stuff doesn't add to CO2. All CO2 comes from this stuff. And just in case you didn't see, I'm saying that the dead volume contributes 0 to CO2 production, where the functional volume contributes all of the CO2 production. So if there was no dead space, let's say, assume again that we have no dead space, then we would say that the partial pressure of expired CO2, I'm not talking about dead expired, I'm not talking about throw it away expired, I'm talking about breathing out. The partial pressure of expired CO2, the PE CO2, would equal the partial pressure of the alveolar CO2, the PA CO2. So if there was no dead space, all of the space in our lungs would be alveolar. There would be no conducting, there would be no non-functional alveoli. All of the volume would be functional alveoli, and so all of the volume that exchanged CO2 would be the exact same volume that came out, and so the partial pressure of CO2 that we breathed out would be the exact same as the partial pressure at the alveoli. In other words, when the tidal volume is equal to the functional volume, there is no dead space. PE CO2 equals PA CO2. Now, I've already basically covered most of this, but the important concept is that we can't measure directly alveolar air. So how do we do it? We get arterial blood gas, and that tells us what the alveolar air was because they equilibrate based on partial pressures. If I remember right, this is called Henry's Law. So my P big A CO2, the alveolar CO2, is going to equal the P little a, or the arterial CO2. Just as a side note, depending on what you're reading, if you're reading about a guy that studies arteries, they're going to use the big A for arteries. And if you read the guy that studies lungs, he's going to use the big A for alveoli. But the generally accepted physiological nomenclature is that big A's are alveolar and little a's are arterial or artery. And we determine the alveolar CO2 by sampling the arterial CO2. Now before I go into these equations, let me just draw out for you what it's saying. Here is my alveoli, and I'm going to say that it has a volume of 3. I don't know what the units are, it's just a volume of 3. And then here's the conducting airspace, and then there's the rest of the world that comes out off of that conducting airspace. I'm going to say that the conducting airspace has a volume of 1. The conducting airspace, this is my dead space. So whenever I get 4 units of CO2, so my CO2 here, CO2, the partial pressure is equal to 4. Whenever the 4 units come in here, it's going to be breathed out, and it's going to mix with this volume of dead space. So the total volume here is 4. The total, or the tidal volume, is 4. And so if I say the functional volume, the volume that's functional over the volume, the total volume, is going to equal 75%, then I would also expect that I would breathe out a 75% of the pressure, 75% of the pressure of CO2 would be reduced to 75% of its original value, so that P big A CO2 divided by the expired PE CO2 would also equal 75%. Or in other words, the functional volume over the tidal volume, or the percent of functional space, is going to equal the ratio of expired CO2 to alveolar CO2. Or we can calculate based on the dead space by subtracting the expired CO2 from the alveolar CO2, saying the difference between the two, and finding the percent of dead space that way. So then dead space can be calculated by the tidal volume times this ratio. And then you can simply, instead of using P big A CO2, you can replace that with P little a CO2 from the arterial blood gas. And there's your calculation for dead space. And that's basically what I said here. You modify the equation so that the partial pressure is from the arterial blood. And then you come up with this equation, which is essentially the same thing. And the bottom line is that dead space can be calculated, but in order to calculate it, you have to get 3 different measurements. You have to have the tidal volume from spirometry, you have to determine the exhaled or expired CO2, and you also have to determine the arterial CO2. We can think of this in 2 ways as a thought experiment, just to make sure that you understand. Assuming that dead space is 0, what would that mean? It would mean that the exhaled CO2 is the same as the alveolar CO2, which is also the same as the arterial CO2. So this minus this would equal 0. So you would have the tidal volume times 0 over something. That becomes 0. Multiply it, it becomes 0. And then you get the dead space is 0. So if dead space is 0, all of this turns to 0, and you get dead space equal to 0. Now the other way to think about it is assume that all of the lung is dead space. And remember, dead space doesn't exchange CO2, so if all of the lung is dead space, you're not going to breathe out any CO2. So you would have that the dead space is equal to the tidal volume, which multiplied by PaCO2 minus 0 divided by PaCO2. So that's going to become 1. So the dead space is going to equal the tidal volume times 1, or the dead space equals the tidal volume. Now quickly, the pulmonary function test, the basics. So I'm not going to cover diffusion tests, I'm not going to cover the special tests, and I'm only going to cover the very high yield basics of spirometry and pressure volume loops. Now we've already covered most of the spirometry. We've got the tidal volume here, we've got inspiratory reserve volume, we've got the expiratory reserve volume. But on this deep breath in, there's another volume we need to talk about really quick. On this deep breath in, starting at the very top with the maximum volume, if you start pushing out, breathing out as hard as you can, there's a certain point after 1 second has passed. So we're going to call this 1 second. And the change in volume at that 1 second, that is called the FEV1, forced expiratory volume after 1 second. Another way to think about this is if we just map it out as the amount of volume that you've breathed out, the amount expired. So we have our maximum breath in, and we start breathing out fast, and we keep pushing out as hard as we can, and then eventually it plateaus. So the volume that we get at 1 second, this is FEV1, that volume right there. At 2 seconds, we get FEV2. At 3 seconds, we get FEV3, which is just barely going up. So you see that the first second, it goes up the most. Second, it goes up a little bit more. It goes up less with each subsequent second, and then eventually you get to where it flattens out and you're not breathing out anymore. And that usually happens somewhere between 3 and 6 seconds. This concept of FEV1 is the most important number. It's the most important number that we're as far as FEVs go. So FEV1, the forced expiratory volume in 1 second. So again, with our spirometer, we have, remember, the forced vital capacity. Let me put that in red because it's the where life exists. The forced vital capacity, where all of life exists, right here. This is the volume maximum you could breathe in all the way to maximum you could breathe out. And then you have that FEV1, which is like after 1 second from the max. So this amount right here would be like your FEV1. And I actually probably should have drawn that a little bit lower. It's usually about 80% in the first second. In the first second, you have around 70 to 80% of your entire forced vital capacity can be pushed out if you forcefully expire that. Now, on a pulmonary function test, a person is considered normal on every number as long as they're between 80% to 120% of their normal. The only exception is with the FEV1 to FVC ratio, where I divide FEV1, I divide that by FVC, that gives me the ratio. That can be normal at 70%. Now the next thing to think of is what is obstructive lung disease and what is restrictive lung disease. I'm going to give you a way to think about it. It's oversimplified, but it will help you whenever you're thinking about what numbers should be. So here's your airway. Here's your alveoli. That's in a normal case. In a restrictive, so this is normal. In restrictive, your airway is the same. Your alveoli, though, is compressed. It's got underneath of it a spring pushing it up. So you're restricting air from coming in. Then in obstructive airway, your alveoli is fine, but your airway is being clamped down. So it's being clamped down. And it's characterized because you're having a hard time getting air out. You could think of O for out, or however that helps you to think of it. So let's think of what the FEV1 would be for each of these, and the FVC would be for each of these. So we got normal, we've got restricted, we've got obstructive. FEV in normal would be normal, FVC would be normal. That makes sense. It's normal, it's normal, it's normal. Okay, so the FEV1 in restricted, how much am I going to be able to get out in that first second? Well, it could be, there is no problem getting air out, so it could be normal, but I have a reduced total volume. If it's reduced a little bit, then it should still, FEV1 should still be normal. But if the total volume is reduced a lot, then it could be, so if it's severe, it could be reduced. And of course, it's obvious I have less volume. I have less volume, less alveolar volume, because it's restricted. It's hard to open it all the way. And so this should be the forced vital capacity. The total volume you can breathe in and out is going to be reduced. Because I don't have a problem getting it out, I do have a problem getting it in, so that volume can't get all the way filled. Now in obstructive, I have no problem with the volume. I can get the air in. It might take me a little bit longer. I can get it in, but I have the whole total volume. So this could be normal, except in extremely severe, I'm going to put EX, extremely severe, it could be reduced. But in general, we're going to think of it as normal. And the FEV1, we're having problems getting air in and out. Like we're not having problems filling it up, but we are having problems getting the air in and back out. So the FEV1 is going to be reduced. Now let's talk about the ratio. The FEV1 to FVC ratio, whenever we get, this is the moneymaker right here, whenever we get all of this other stuff figured out, the FEV1 to FVC ratio in a normal person's normal is normal, 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 normal. Now in somebody who has got a restricted lung disease, the FVC and the FEV1 could both be reduced, but the FVC is going to be reduced more. The FEV1 could be normal or reduced. So that tells me the FVC is going to be way more reduced. So we're going to see if the bottom number is way more reduced, it's going to cause an increase in the ratio. So the ratio will be increased or normal. On the other hand, with obstructive, remember I don't have a problem with my volume, so my FVC, if it is reduced, it's only mildly reduced. But my FEV1 is going to be severely, I'm having a lot of trouble pushing that air out. So the number on top will go down while the number on the bottom stays the same, so that will cause my ratio to be reduced. And as a general rule, although restrictive can have increased or normal ratios, obstructive will always have decreased FEV1 to FVC ratios. Now let's take this chart. So we have our normal, our restricted, and our obstructive processes. And let's take this and come up with an algorithm. So the very first thing I want to do is I want to look at the ratio. Is it high, normal, or low? Let's suppose that it's low. The very next thing I'm going to do is look at the FVC. So I told you every time it's low, always going to have obstruction. So that's the general rule. So then I look at the FVC, and the reason I look at the FVC is because if it's a normal FVC, I just go ahead and say it's obstruction. If there's a low FVC, remember that the low FVC can be present in either one of these things. So if I have a reduced ratio, I know there's obstruction. If the FVC is also low, then I either have severe obstruction or I have a mixed obstructive process and a restrictive process. Now let's suppose that we see our ratio as high or normal. Even when it's normal, you still look at the FVC as your next step. So if your FVC is also normal or high, well, let's just say both of these are normal, that's normal lung mechanics. Remember, normal. If everything's normal, we got normal, everything's normal. But also remember, we did say earlier that if you are exercising or a male or all the different things that can change the functional vital or the forced vital capacity, this forced vital capacity can be altered if you're working out. So if everything is high, it can still be normal mechanics. You're just really in good shape. And then lastly, remember, if the FVC is reduced, FVC is low, we have restrictive. By the way, I need to give credit. Dr. Eric Strong is where I found this algorithm. He has an entire series on pulmonary function tests on YouTube. And then just as a review summary, the FEV to FVC ratio is low. We have obstruction or mix. If the FEV-FVC ratio is normal or high, anything else, it doesn't really matter if it's anything else. We need to move on to the FVC to know what it is. FVC is low, it's restrictive. Okay, last thing I want to talk about are flow volume loops. So we have the flow recorded as the y-axis, the volume of air recorded on the x-axis. The first thing I want to point out is that 0 is over here, and we're increasing to the left. Next is we got to shrink this down just a little bit because this is going to be where flow is 0, and we can actually have negative flow. We'll put a -4 there, and we'll put a +8 right here. And we're measuring flow as moving out of the lungs. So if air is moving into the lungs, it would be negative. Now in a normal flow volume loop, we start down here at 0, or at we'll say volume of +4, +5, +6 even. We're saying that we've breathed all the way in, and we breathe in as deeply as we possibly can. We're going to start breathing out. So we breathe out, and this is the flow is the y-axis, and then so I'm still breathing out. I'm just breathing out less fast. And then all of a sudden I stop breathing out and I start breathing in. Couple of things to note. I didn't get all the way down to 0, so I have a residual volume. And whatever I got all the way up to, this includes the residual volume, so this would be total lung capacity. Next, this is expiration, this is inspiration. And then the distance between here and here is my forced vital capacity, or my vital capacity for short. There are two other bits of information this thing can give you. The first one is at the very top of this. This is my peak expiratory flow rate. So in essence, what it's saying is that when I first start breathing out, it starts off slowly, and after just a little bit of air has left my lungs, I'm breathing out as fast as I possibly can, and then I start breathing out slower and slower until I have everything completely out. Another important thing to note is that this doesn't tell me the time. It's not saying that I breathe in, that it takes the same amount of time to breathe in that it takes to breathe out. This does not have time anywhere on it. The time is basically within the flow, so I'm saying liters per second, but I can't look at this and determine based on size how much time something took. For time, I would need a volume time slope. Volume time slope, we would start off down here. And the thing you'll notice about this graph is that it starts at 0 and counts backwards on the way up. And so I start here at my total lung capacity, and I start breathing out quickly, and then it slowly slopes off, and then it levels out to 0. And then even if I go a little bit further, I start breathing back in. And so that's my time volume. So you can get some of the same numbers. So my functional vital capacity, this is right here, functional vital capacity, forced vital capacity. That's my FVC right there. The other thing is like the steepest slope here, the steepest part of that slope, if you think of flow is volume over time, so that's the slope. The steepest part of that slope is the peak expiratory flow rate. So we can actually compare the two graphs that we just made. So the volume versus time graph, where we can get the peak expiratory flow rate as the slope, or the flow volume curve, where it's the highest point. The functional vital capacity over here is the highest point, whereas over here it's the difference between the minimum and maximum X values. And so a lot of times you're going to get this flow versus volume curve, and so it's giving you a lot of information. It's giving you residual volume, total lung capacity, FVC, it's giving you peak expiratory flow rate. But there's something else in this curve that is not immediately apparent, and that's the shape. The shape of the curve actually gives you even more information. So assume the curve I just drew for you was the normal shape. So I have my flow and my volume, and the normal shape is something, I'm going to draw my normal shape in blue, something like this. I'll draw obstructive process in red. So obstructive process, it's not going to go quite as high on the flow rate. This is a mild obstruction. You can get a severe obstruction. You'll see that there's something called coving, and this coving process, so you see it's moderately smaller, and it can be anywhere from moderately to severely smaller than the normal, but you have this coving right here. This tells me that there's obstruction. What you can think of is that this is an O, this coving O stands for obstruction. And so another thing to point out is that even though I've shown a difference in the total volume and the total lung capacity and in the function the forced vital capacity, the FVC, the difference isn't very much. Now I'm going to draw a restrictive process, and it's going to be right in black, and you'll see that there's a marked difference in the total lung capacity, and a marked difference in the forced vital capacity. So in restrictive, you see the forced vital capacity is much less. Remember, we said that this space right here is forced vital capacity. But what you'll also notice is the shape is the same. So restrictive, shape is the same, but the forced vital capacity is less, so it's a smaller curve. You'll also know that the peak expiratory flow rate on restrictive was not that much different than normal, but the peak expiratory flow rate on obstructive was. Remember, we're having trouble pushing the air out, so the flow rate will be reduced. So with restrictive, the PEFR is nearly the same. So like I said, with obstructive, you get coving, your FVC is nearly normal, and your peak expiratory flow rate is reduced. There are three other shapes. I'm not even talking about mixed, so you could also have a mixed obstructive and restrictive process that would have a different shape than this. But we're not even going to go into that. But besides a mixed process, there are three other shapes that you should be familiar with, and they basically show extrathoracic airway, so such as the trachea. So if the trachea is blocked, or if there's a block, there could be a block when you're breathing in, there can be a block when you're breathing out, and there can be a block on both. And those are going to create distinct patterns on your respiratory curves. And to see what those are, I refer you to Google Eric Strong Pulmonary Function Test and then click on his YouTube page. I believe it's the second video in his series. There are other values that are less important on the PFTs. We already talked about the peak expiratory flow rate. Not extremely important, but it can be mildly reduced whenever you have obstructive process. The FEF 2575, this is the flow from 25 to 75% of the FVC being excelled. And this is typically used for small airway obstructions, not always valuable or valid. The other thing is maximal voluntary ventilation. This is the maximum volume that a person can breathe in 1 minute, so they start to breathe as much and as fast and as hard as they can for a whole minute, and it's the whole volume that they've been able to breathe in and out in that time.